So good afternoon and welcome to this very important webinar for our network, ReCONNET. We know that in the framework of our webinar and educational activity, a lot of important topics are discussed, and we know that all the topics that we are discussing is mainly for sharing knowledge regarding very important topic in rare and complex disease. Today, we are very lucky. I have the pleasure to introduce Professor Sylvia Kamphuis. She is an associate professor in the Erasmus University. She is a rheumatologist in the Sophia Children's Hospital, and she will perform a talk on a very important topic regarding a rare aspect of lupus, lupus affecting young people, and how to proceed in the management, in the approach in the adults. So we have a lot of potential question regarding this topic, but I'm quite sure that this presentation will explain very important aspects. So I give the floor to Professor Kamphuis for her talk regarding young people with childhood onset lupus. Do we need to have a different approach in adults? Please, Sylvia, the floor is yours.
Thank you, Sarah, for your nice introduction. And dear audience, I just heard it's a very broad audience with health professionals, but also patients. So I'll try to approach this in a way that everyone can understand it. But if not, please put your questions in the chat, even during the talk. And there's ample room, a lot of room to answer questions at the end. I'll present first a lecture that's, I think, about 20-25 minutes. And then I have one, and if there's time, two clinical cases where actually you get to know the children with lupus. Those are complex cases, so not our regular ones. But I thought in my lecture, I will focus on outcome of the children with lupus after they turn 18. So the patients that are seen in the rheumatology department. In the second part of the talk, I will focus on one, and if there's time, two clinical cases. Those are children. So those are the ones that, you see them if they're older. And I thought it's good, again, if you get a little bit of a feeling how severe this disease can be. So we'll start right away. These are my disclosures. So yes, children do have lupus too. It's a rare disease. It's less than 1 per 10,000 prevalence, and it depends on ethnicity. So mostly in colored people, and the same in children, the incidence is higher, and in whites, the incidence is around 1 in 10,000. So it's more prevalent in non-white people. It is actually the same disease as adult onset SLE. And adult onset is defined as onset after 18 years of age. So everything below 18 is seen as childhood onset lupus. It has the same etiology, same pathogenesis. The clinical manifestations basically are the same as well. It's a very heterogeneous disease, we all know that. And also we recognize the disease the same way as we do in adults. So you use autoantibodies, but also the classification criteria to see whether a person fits into this disease or not. But of course, I wouldn't have this talk if I had something to add, because unfortunately for the children, it's a more severe disease. So children, in the end, and these are all older studies, as you can see on the right side, children have a higher disease activity at diagnosis, but also over time. They have more renal and CNS involvement. They accrue that damage much earlier, of course, because they're younger at disease presentation. And the age of disease presentation is mostly around 11, 12 years. Quite a bad age to get a disease, actually, to say. And the bad age, specifically, as this is the start of puberty, 11, 12 years is the start of independence. And then you have this disease, this lifelong disease that makes you sick, that makes you need to take medication, and it's kind of hard. And you don't want to have your parents around anymore, but you cannot not have them if you have this disease at the start. And lastly, to mention, the mortality is much higher than compared to adults. I'll come to that in more detail in my next slide. So first, addressing the damage. That is something that we as pediatricians, of course, want to avoid. The children have a life to go. They're only 10, 12 years old, actually 12, 13 years old at diagnosis. And you don't want them to have already, damage if they enter adulthood. What we most often see until now is musculoskeletal damage, renal damage, ocular damage, or neuropsychiatric damage. This is due to the disease, but also to its treatment. And around 50% of the damage in the current studies is caused by corticosteroids, so prednisone. Hopefully, in future, when we use less corticosteroids, the damage will be less too. Predictors of damage are disease duration and disease activity over time. And if you take this together with my first two sentences, they have a higher chance because the disease duration at 18 is already at 8, or at least 8 in the 12-year-olds, in the 10 years old, but it's higher, the disease duration, when you're getting the disease at 12 and you are 25, or if you get the disease at 21. So that's a big difference that you have to make from the start. A 20-year-old with lupus with childhood onset lupus is not the same 20-year-old with a new diagnosis of lupus, completely different. And again, they have a higher disease activity over time, so a higher chance of developing damage for that reason as well. And I want to show you data from our own study in adults that had childhood onset lupus. This is published in Arthritis Rheumatology a few years ago. And on the left now you see a table with the patient characteristics regarding error of diagnosis. That's what you see here. And it's quite evenly distributed against over the different eras. And of course, they had to be 18 years at entry. So after 2000, we did the study in 2012, so there were only a few after 2000. This is the mean SLEDAI and the treatments. And I just summarized it for you on the right side. More of the details, I'll just leave this a bit on the side, like this. 90% of our study participants were female. The median age at study visit was 33 years. That's quite young. So you're still, basically, I would say, a young adult, but they already had the disease for a median of 20 years. We're doing a study in the Netherlands, so 72% of patients were white and the others were non-white and primarily Asian or African American. Regarding disease activity, I summarized it here. So the good news is 65% had a SLEDAI less than 4. So this could be clinically inactive or clinical remission. However, and this also means that 35 after 20 years of disease duration still have quite active disease. And that's what you can see here. So that's 23 with the SLEDAI of 5 to 7 and even 14, so 1/6 with a SLEDAI above 8. So it's still a flaring disease even after these 20 years of disease duration. A medication, again, this is necessary still to get to this SLEDAI below 4. 87% still had immunosuppressive medication. None had any medication, because if they didn't have immunosuppressive medication, they had other medication to treat complications of the disease. And because we only listed the antihypertensives that were needed for the lupus. Of course, not if they needed it for something else. And what we also found shocking is that still 51% were still using corticosteroids. If you look in more detail for the damage, we counted the patients with an SDI of more than 1, and that's 62%. So 62%, the majority, had at least some damage. And again, just bear in mind, these are median age 33 years old, but median disease duration of 20 years. It's the same as in literature. I just listed neuropsychiatric, renal, musculoskeletal, and ocular are the most frequent complications, most frequent locations of the damage. But actually quite shocking, I would say, and it really lists the problem with the children with lupus right now, is that it really increased the frequency over time. So here, the first 10 years are basically still within pediatrics and a little bit in the adult department. But 11 to 20 years, that means our patients are around 20 to 25 years of age. And then you already have 20 patients, so half of the patients in our cohort already had damage. And the older they get, the more damage. And if you have the disease for more than 30 years, which of course sounds like you're very, very old, but our patients only are 45 or 50. I wouldn't say that's quite old, but 90%, if you see it in the bar, have developed damage already. And of course, you're thinking, what kind of damage is this? Neuropsychiatric, joints, what do we mean? And that's what I listed here. And just bear in mind, these are the patients with renal involvement. That were 67 in our cohort. So 2/3 of our cohort developed renal involvement. A quarter has renal failure and 14% had a renal transplant. And the median age was quite young at 24 years of age. If you look at the total cohort of 111 patients, and then calculate the damage for the CNS involvement, because of course cognitive involvement is quite frequent in children, 21% had damage, and 7% of those had CNS infarction. The other big player in the damage is the neuropathy damage, the neuropathy damage, and mostly the cognitive damage. And this is only listed not by patients telling us this, but by doctors reporting this in their medical letters. So with every patient in this cohort, we contacted the hospital where they were in treatment, and we only listed the damage if it was listed in the letters from the treating physicians. So if any, I think it's an underestimation than an overestimation. We thought it was quite shocking. And the other thing which I found was quite shocking is 5% with a myocardial infarction with a median age of 39 years of age developing this myocardial infarction. Also quite some joint damage with a quarter having osteonecrosis. Of course, this should decrease if we decrease our steroids or prednisone dosing or treatment in children and in adults. 5% had a knee or hip replacement already at a young age, 34 years. And mostly the hip, of course, is mostly due to osteonecrosis. So this is about the damage. How about quality of life? Of course, we looked into that as well. We used the SF36, and I'll walk you through the slides, to the graphs. So here you see the lupus patients versus healthy controls. And yes, the health-related quality of life is less significantly. But the interesting thing is this is the social functioning, the physical functioning, bodily pain. I'm just a little bit looking on the RP right now. These are all decreased. What is quite interesting that the role emotional and the mental health actually is compared. So these were a tough kind of people. The patients that we saw were actually quite satisfied. They had accepted their disease and but still had lots of medication, but did well on the mental part. If you look into more detail within the population, so these are just lupus patients, and here we divided regarding the SLEDAI low, less than 4, and intermediate and high, that you see that the intermediate and the high group actually had lower health-related quality of life. And interestingly, that was quite more regarding also the mental part, but also the physical part, but not the physical functioning. Then here you can see, this was actually a question that one of our students had, like how does active skin and alopecia, the things that people see on you, influence your quality of life? And I thought it was quite impressive that the ones that have skin disease and hair loss were comparable to the ones regarding health-related quality of life. They were comparable to the ones with a SLEDAI above 8. And a SLEDAI above 8, then you're having a quite active disease. And then also quite remarkable, we don't want, as doctors, we don't want people to have damage. But actually, if you look into health-related quality of life, it was not different in general, between the ones that had damage or not. But logically, it was different regarding physical functioning. And I think this is because damage can be in many organ systems. And if you have joint damage, it kind of difference if you have like a cataract in your eyes, or if you have a cognitive decline, then your physical functioning may also be less. Okay. So in the end, summarizing, health-related quality is less in these patients, and it depends on SLEDAI, high SLEDAI, less quality of life. It didn't depend that much on damage, but it did depend on like features, skin features, hair loss that actually patients can express or can be seen by others in their daily life. Of course, in childhood, you have to go to school, and that will be the basis of getting a job. So first of all, when looking at education, that's on the left side, we asked them questions, and we asked whether the course of education was negatively affected due to the lupus. 86% said yes. If, oh, I'm sorry, it's a double one. I didn't see that. A choice of the career actually negatively affected in 60%. We were a bit disappointed that this 58% was not less, because if you have the course of education negatively influenced, you also get a chance to adjust your education to fit with a job that you could do when you're adults. Unfortunately, that's not the case here. I apologize for this one. Then we had some extra questions that only 79 of the cohort of patients just gave to us. And here you can see that 60% said we reduced the working hours. 27% said, well, we not only reduced, but we quit actually working, partly or mostly due to the lupus. And 4%, that's actually quite good, never worked. So luckily, most of the patients started working, but had to quit or do less work. Work disabled in the Netherlands, that's something that a specific physician gives you a judgment, a physical examination, and then you're work disabled. So it's not something that the patients can decide for themselves. And you can be work disabled for like 20% or 50%. And we calculated all of them, again, from the medical letters from the doctors. And half of our patients were work disabled, pretty high. And from these patients, these 79, to get an idea which patients there were, because of course it's biased from the whole group, those of them had 83% had damage. Then if you look here in the work status in the end, I'll remove myself a little bit here. You see compared to the Dutch norm, actually it's not that much of a difference of full time, but you can actually see that, that this is primarily females in our cohort. So this is also only females that is shown here, the Dutch norm for females. That actually it's only a bit less in the full-time work, but really much more in the unemployed, and also less patients working part-time. So probably these are the ones with very mild disease, and this is the large majority of the patients in our cohort. Then something quite serious is the mortality, of course. And that's something that's quite sad because the mortality rate is much higher in children. This is a standard mortality rate, standardized mortality rate, so adjusted for age. And even without below 10 years, where the disease is actually very rare, childhood onset lupus, mortality rate is quite high. But still, if you compare it to like your 40-year-old patient, it's still 4 times as high. And here you can see the dividing over the decrease over the years in standardized mortality rate. And if you take all the lupus patients, so from 0 till 20, then it's still much, much higher. So which patients do die? Let's start here first. It's basically infection, end-stage kidney disease, but also severe lupus flare. And it's mostly in the first years of their disease. So in their early 2 to 3 years after diagnosis. And the highest risk actually is for infection in the first year of diagnosis due to the probably higher dosage of the immunosuppressive, lots are on steroids then, but also on the intrinsic dysfunction of the immune system shortly after diagnosis. And again, if you look at 10-year survival rates, so this is different from the standardized mortality rate, but 10-year survival, actually it's improved a lot. So 80% is in the lower income countries with less access to adequate medication. 92 to 95, I think right now is for the higher income countries. But that still means we lose 5 to 8% of our patients. And up to 15% will have died before they're 30 years of age. So I don't have to stress again, I think again, that this is a severe disease. And, you know, with the damage, the decreased health-related quality of life, the less chances to fulfill the education you want to do, less chance of a job, and in the end, much higher chance of dying from this disease will make the summary that this is a much more severe disease than in adults quite strong. So why is it that it's a more strong disease? And this might very well have to do with genetic burden. It's not explaining everything, but I would like to focus a bit on that so that you know it's not something that it's just not taking the meds, because that happens in specifically the teenagers. I think in almost all, that they don't take their meds once or twice or once or twice a period in their life, and specifically in their adolescent years. So genetic burden, that's another thing why this disease is much more severe, and there's actually data to support this. First of all, lupus is among the autoimmune diseases that have the highest lambda, and that's actually a factor that's showing the disease risk for siblings compared to the population risk, divided by the population risk, and that's the highest, 30 in lupus patients. We did a study with my boss. I spent 2 years in Toronto in sick kids. Earl Silverman and Daniela actually wrote the paper in the end with us together. Showed that indeed, if you compare childhood-onset lupus patients with adult-onset lupus patients, that there's a linear relation between genetic risk and age of lupus diagnosis. So the younger you are, the higher your genetic risk is. And if you look at which risk scores are higher in children, then it's mostly the non-HLA related genetic risk score that is higher in children with lupus. There's also a large study by the Lupus Family Registry in Oklahoma of almost 1,400 patients. Those included adult and childhood onset lupus patients as well. And you see actually overall at different ethnicities that over age, because here is the age of onset on the x-axis, you can see it's much higher in younger patients, higher genetic risk than if you're older. And they not only showed in this paper that it's the higher risk, but also a more severe phenotype. So probably those risk factors predispose to more organ involvement and therefore higher disease activity. I also want to share you a little bit, when I talk about genetics, about monogenic disease, because you'll see those patients more and more in your department. It's actually quite rare. So lupus in children is rare. This is really, really rare. So 1 in 100,000 you must think of, but it's something to at least know the existence of. And you'll see the diagnosis with your patients from the pediatric colleagues. And we call it monogenic lupus. This is a review in 2018 or 19, but there's actually more reviews coming up very soon. There's over 30 genes now associated with a clinical picture that sometimes is very much like lupus, sometimes a little less. And most often, I think, if you have a patient with chilblains, that's something to think about. Even maybe, you know, with the higher availability of genetics and more discovery of genes related to lupus, maybe even in your young adults at the outpatient clinic, where you think this is quite weird, this is quite a typical presentation. This maybe could be monogenic lupus, but then I'm stretching it out a little bit more than the knowledge that we have right now. But at least in my population, I have a few monogenic diseases, children with monogenic diseases. So summarizing the damage, but also summarizing and going back to the title of my talk, do our patients, our children, when they grow up and become adults and appear at your department, do they need special care? And I think that's a big yes. Due to the severity of the disease, they have a much higher risk of developing, as I showed you, premature atherosclerosis, premature osteoporosis and osteonecrosis, and also premature renal impairment and end-stage renal disease. And this happens in their early 20s, early 30s. So be aware of those patients, and maybe you should check them for atherosclerosis much earlier than you would do in your other lupus patients, and advise them a healthy lifestyle. I think in the early 20s, it's kind of difficult, but at 25, the pubertal brain is, easing down a bit, and there's more sense, and hopefully more sense also to live a healthy life. I think in the adolescents and the young adults, it's just most important to stay in touch with them. That's my next slide, for age-appropriate care. I think that's really important. Teenager, but also young adults, if you don't ask, they won't tell. So if you don't ask whether they have joint problems, if you don't do a physical, they might have arthritis and don't tell them, but just don't do that much, so their pain will be less. So I think that's the big message I can give to you. If you don't ask, they don't tell. And some even will be reluctant to tell anything, like if you don't specifically ask, I won't tell. So the most important message is, see 20-year-old adolescents that had the disease for already 10 years or 5 years, different as a newly diagnosed patient of 20-year-olds. Their psychosocial history is also completely different. They have to have their school, but also maybe their jobs when they were young, and doing it besides school, have to do that with the disease being there, with taking their meds being there. The other thing I want to stress here is that autoimmune serology, we all know over time it goes down, even in your patients. So if you get a patient from me, from my department, in some patients, luckily not in all, I would say, but in some, the ANA may have gone negative. And yes, if you take another patient from a colleague, of course you have the responsibility to check whether the diagnosis was made correctly and whether there's anything, that is something new. Actually, I think it's quite nice to have a fresh look, but don't make the mistake that if they're ANA negative, if they have mild disease at that point, oh, everything is fine, I can stop the meds, and even say maybe they don't even have lupus anymore. I think I showed you that lupus in children is a severe disease, and we try to ease the disease down, even, when they're 16, 17, 18, also in discussions, shared decision with the teenagers. I don't take the meds down that easily because it's so important for them to finish their schools, to get a job. So we don't want to risk a flare. My primary goal with adolescents is to get rid of the prednisone, and if they're stable on Plaquenil and MMF, we won't change that much, only if their disease is really at ease and if they don't have organ involvement. So, finalizing, I think with what we showed right now, we really need to do better. And that's my last 2 slides. I think we need to have a more focused treatment, a treat-to-target treatment, and that's the initiatives are going on right now in the adult rheumatology department, but not yet in the pediatrics. But we're working on that. And we're actually working on better understanding of disease pathogenesis. There are quite some groups that do translational research. My group is doing this as well, but I didn't have time to go into this today. We need to better understand the disease biologically, so we can be much more upfront in treating disease flares, but also in decreasing the meds when they're in, disease remission that is quite stable, and develop treat-to-target treatment strategies. And this is actually an initiative started 2 years ago, I think, right now, by Eve Smith and Michael Beresford in the UK, in Liverpool and London. And we're doing this with 25 experts. We already published the first paper, and the second one is now submitted. And the first paper is regarding the development of a childhood lupus low disease activity scale. And just look into the paper. The highest difference is the prednisone dosing, of course, because children for 10 years are lower weight than children that are 17 years of age. So we actually made a different definition regarding the use of prednisone, and we said it should be less than 0.515 per kilogram per day. That's what pediatricians do. We calculate a maximum of 7.5, and in clinical remission, maximum of 5. And that's actually where I would like to stop the last part of my talk. Yes, childhood onset lupus is the same, but also quite different. It's a more severe disease, higher disease activity, more damage, much higher mortality. Be aware of this and really focus on prevention of, I think at this point, primarily atherosclerotic damage in the 2030s, because that can be silent killers. Maybe even, I think we need more data, but maybe even screen them cardiovascular. Thank you. If there are no burning questions right now, I will continue to start with case 1, and I think I'll just do one case in the last 5 to 10 minutes to have a chance to do the questions afterwards. So maybe stretch a little bit, and I'll prepare you for a case of a young child, one of the youngest in my population, and this is Iris. And she presented at 9 years of age, actually 3 years ago, almost 3.5 years ago. She really looks like this girl, but this is a girl that I picked from internet, so it's not her, but she really looked like her. She presented with fever, general malaise, and actually quite extensive muscle weakness and myalgia. She had joint pains and morning stiffness, but no arthritis. She was unable to walk, she was wheelchair dependent, and at physical examination, we saw a painly black girl. She had actually the characteristics of maybe the juvenile dermatomyositis, which you can see with only a few Gottmans, a little bit of puffy eyelids, and severe muscle weakness, and then, of course, primarily proximal. Oh, I'm sorry, she did have some arthritis at first. I forgot. Her blood work was quite significantly abnormal. She had a high ESR, also a high CRP, which we mostly see in infectious disease or serositis. But at that point, I couldn't find serositis, so might also be just regarding the severeness of the disease. She had a little bit of ACET, but her muscle enzymes otherwise were normal. Leukocytes were a bit low, and otherwise signs of inflammation. She had a positive CUMS and also a low hemoglobin, so also hemolytic anemia. And her autoimmune serology made it clear that the diagnosis was not juvenile dermatomyositis, but she has childhood onset lupus. So to us, this is a reason to start treatments with Plaquenil steroids and DMARD. First of all, we do other investigations to screen. We did a X-ray of her thorax, which was normal, ultrasound of her heart, which was normal. Because she had these Gottmans papillae and we didn't know for sure, we only got of course, the autoimmune serology later on. We did a biopsy, and actually it didn't fit with dermatomyositis, and it really fitted with the autoimmune serology that we discovered. She really fitted the pathology really fitted with lupus. Because of her young age, we also did genetics. We did a VEST panel for immunodeficiency and autoinflammatory disease, but this was negative. So this is not a monogenic lupus, at least not with the knowledge that we have right now of the genes involved with lupus, but actually quite a sick patient. We treated her with methylpredpols, oral prednisone. If you're lower, we actually go a bit higher than 1 per kg, because we think the metabolism of the prednisone is much higher in younger kids. We treat her with MMF and Plaquenil. If we start prednisone in my department, we always design a schedule of 3 months to see, and if we can taper, we reconsider if our treatment regarding DMARD and maybe biological is still, if we need a biological to add, is necessary if we can taper prednisone. So if in her follow-up 6 months later, she did actually quite well. She had a good response. We had no problem in tapering her steroids. And specifically with the myositis, we are a bit careful to actually stop the medication. And she was still at 6 months on 5 milligrams, so a low dose. Just too high to be in low LDAS, if you remember what we have designed right now. But she was actually doing well. She wasn't weak anymore. She could walk, she could sit. She actually, her physical examination, it was normal. And these are the childhood myositis assessment skills. Maybe you know the Kendall, but this is the maximum score, and the Kendall maximum is 80. So it's pretty good. However, she still had exercise intolerance. And on our x-ray now, so this was not a diagnosis, we saw elevated diaphragm on both sides. And when we did an ultrasound, and later on we also performed a dynamic MRI, it really showed that the diaphragm moved less. So is this a shrinking lung? Is this still due to muscular weakness? We really couldn't find with the literature what was going on, because even if it's a shrinking lung due to fibrosis, but she didn't have clinical signs of pleuritis actually in the past, but we can be sure that maybe the diaphragm couldn't move because the lungs were too fibrotic. We did, of course, pulmonary function, but you have to imagine she's 10 and she had really bad exercise intolerance. And you can see her lung function was actually pretty bad at 6 weeks. And repeated that again, with hopefully a little bit better. Indeed, it was a little bit better, but still, this is around 30% of what was normal for her age. So, of course, we weren't happy with this. And while thinking about what to do, she actually developed a flare. So here she was on low-dose prednisone, MMF, and Plaquenil, and she did a new onset arthritis, and actually at that point, a very painful pleuritis. Of course, in children, we need to monitor growth. And if you start this high of steroids, as she got, they won't grow for the first 6 months. Mostly they will recover if we taper the prednisone at 6 months, then they start growing again. But here she did not grow at all, which could be a bit early and maybe explained by the flare that she might have had developed maybe even from 7 months. So we treated her now with an increase in prednisone, this flare. So we increased to 1 milligram per kilogram per day and thought, well, maybe she's one of those persons that need a little bit of more prednisone. So the idea was to increase the steroids and then taper down and give her a little chance of not having to increase or upgrade her treatment with a biological or something else. So at 10 months, 2 months later, we're very much looking for this target to actually decrease the prednisone and to get into low lupus disease activity. We actually tapered her prednisone to half of the dosage 2 months before, but still we did not see any improvement and her lung function was still quite poor. So what would you do? Maybe it's a good point to get a little bit of active, even if I can't see or hear you right now. But what would you do? And maybe from the things that I already said is that you already guessed that we added a biological. And at that point, we had the belimumab subcutaneous pharmacokinetic study in my department, and we could add her in, include her in the study. Actually, we waited to get her included because she really wanted herself to get subcutaneous injections and not IV. So we actually waited a little bit to include her. That her steroids were down to a level that she actually could be included in the study, all in shared decision with the patient and their parents. So this actually gave quite a good response. So we started at 10 months after diagnosis, and now this is a follow-up at 20 months. She didn't have any flares. We could decrease her steroids to now 0.25, but mind you, she was much lower before her flare. The patient and the parents actually were quite happy. She didn't flare, she was quite stable, she could go to school, she was happy. But her growth, you can see on the side, and for the ones not familiar to look at these graphs, here's the age and here's the length. So it's quite normal. These are the values. So in green, the normal values for growth in children in the Netherlands. And here in age, you of course grow. And this is the median for the mean height of all patients in the of all normal Dutch still healthy controlled children. And you can see here that she, well, maybe a little bit of growth, but in the end hardly did anything. And these are 20 months, almost 2 years. So this is the first 20 months. This is exceptional. So mostly they would start growing around here. So we felt we need to do something. This is not enough. Currently, where she's on MMF, she's on Plaquenil, and she had belimumab sub-Q, but we weren't happy with the steroids, we weren't happy with the lungs, and we weren't happy with the growth. So we felt we need to move on. We need to really follow the target of low lupus disease activity. We've waited enough, and let's do something else. So here, what would you do? And mind you, we already have belimumab, so she's quite immunosuppressed. Well, you could actually say we could add cyclophosphamide, or you could actually say we add rituximab. We choose rituximab, and the reason why is because there's some data in adults that the combination of belimumab and rituximab is actually synergistic, so it can add more. And we are a little bit reluctant to add cyclophosphamide because this girl is still so young. She might need this further on life. And we all know that the cumulative dose of cyclophosphamide actually is more decisive regarding the later on well, complication or side effects like infertility or bladder cancer. So if you can limit cyclophosphamide in childhood, I think most pediatricians will make the choice to add in biologics and not add in cyclophosphamide anymore. So we added in rituximab, and that's here. The last slide I have, actually that worked out pretty well. So we're now at 36. Well, this is actually in last September. I didn't update yet, but we're on, did I? Yeah, I think I did update it today. You can actually see a growth curve. It's quite impressive. So right on of here, we started to add rituximab, and then finally, maybe she just needed a little bit of a hinge, she started growing again. So we now have MMF, plaquenil, belimumab, and rituximab every 6 months. She starts growing. We could stop the prednisone on a slow taper in May 2023. So she was diagnosed in 2020. So 2.5 years after her diagnosis. So for us, that's quite long. So she's really a severe disease to us as well. Her pulmonary function very nicely improved. And this is her most recent pulmonary function, and actually leads her to be a little bit more exercise limited than her friends, but actually now is on sports again and functions normally. And finally, with being off prednisone, and SLEDAI, I think right now is only determined by the anti-double-stranded DNA that she had. She's in a low lupus disease activity state. So what's the take home from this case? And I think from all children with lupus, but that won't be different from your adults. Really define your target. Adjust your targets when the target is not reached at the time that you want it to be reached. So mostly that's every 3 months. And specifically keep in mind that steroids can make the patient feel better, but it's not the right way to suppress the disease. You need to modulate the disease, and it's our feeling, I think I share that with the adult rheumatologists as well, that prednisone is not modulating, but just suppressing the disease. And the modulation we need from the DMARDs and from the biological treatments, and if indicated from cyclophosphamide. I think that's the best to do. And as you also can see, we decided for the last 10 years actually already to do a step up like you do in RA, rheumatoid arthritis, and we do in juvenile arthritis. And we published these data too, and it actually works quite well. And herewith, I'll end my talk. Am I happy to answer any questions? I'll stop sharing so we can see each other again.
Thank you so much, Sylvia, for this outstanding presentation. It was a pleasure to listen to the point of view of the pediatric rheumatologist. Very, very interesting. Actually, there are a lot of questions in the chat. I can read some of that. First of all, I think in your experience, but also from the literature data, do the new molecular therapies started on time have improved the condition, at least regarding the mortality of these patients? What do you think about this point?
Well, I think, but it's not published yet, I think it's certainly improved. I think there are two things. So I've started working and specializing in lupus for, well, let's say 15 years right now. And I think with my nurse, 5 years, like 12 years ago, I said 15 years, so 10 years ago. So after 5 years, I think that was starting with, we got all these patients on plaquenil. We were more aggressive in reaching our target. That she also felt, and I also felt, that our patients were doing much better. They didn't have that much flares. We weren't that worried, and it was much more at ease. I'm just negative. That's something Dutch, and negative on wood, I would say. So I won't want to provoke something, but I haven't lost a lupus patient in the 20 years that I've been a clinician. So I'm very happy with that. But that's basically also to be, we are specialized in lupus in our center. I'm with 3 colleagues here. We're doing the same approach, clinical approach. Again, we published a paper on low lupus disease activity, but also on the outcome of our patients. And there, when you compare to other groups and other countries, we're doing quite well. That's not because our other colleagues don't do well. It's because in the Netherlands, we have we're a small country, and we have a very stepwise approach of the health system. So I know my referring pediatricians, they know their referring general practitioners, and I don't have much delay anymore when getting the patients. In the UK, there's also a paper on low lupus disease activity in the UK, which is a much larger cohort. They published on 700 patients, but that's much spread around the country. People, they have damage, I think 10 or 20% of their patients already have damage at presentation. So it means that their starting point, their risk of refractory disease or more severe disease is higher, because I also think in lupus there's a window of opportunity. So I think, and the other thing is that also in the Netherlands, we are lucky to have biologic at our disposal. Actually, I could start it actually at the start if I've treated like lupus patients, lupus nephritis patients with MMF, and we get the pathology back from the renal biopsy, and it's so severe, we can actually start rituximab right away. If I have a severe cytopenic patients, we would do MMF and rituximab also right away. So we're quite aggressively, and we can do that. And I think that's needed for our patients to get a better outcome and to decrease mortality. I think that's a very important message. Maybe one thing, I will stop talking afterwards, but one thing I think it's also important to stress, I'm always a bit surprised that if I'm correct, it's still the case in the UK, that they only can start a biologic like rituximab or belimumab after 2 DMARDs, or only after 6 months. I'm not sure, maybe it changed. And it's kind of weird if you compare to rheumatoid arthritis or JRA, where we can start our treatment with a biologic after even 6 weeks to 3 months. And I think in adults, I hope the focus is changing. So I'm not sure how it's in Italy, but I hope that for lupus patients with their lifelong disease, with their bad outcomes, that at least, the regulatory authorities are more open to aggressive treatment early on.
Oh, thank you. Actually, a lot of things changed, not only for lupus, but also for other diseases in the last, I think, a couple of 2 decades, and the last decade mainly. But probably we have to observe in the future some of the effects of this approach.
Exactly.
Very interesting. Another interesting question is regarding what about the epigenetic role at time of puberty? If there is an association with specific HLA haplotypes?
Oh, that's an excellent question from Professor Guttelow. Thank you. But I must say it's not my area of expertise. So I know about cytokines, genetics, interferon signatures, but I'm not the expert on epigenetics. So I think otherwise than speculating, I think I'll pass on to this question.
Okay. There are other 2 questions. One, do you believe there is a connection between lupus and hormones?
Oh, that's a very good question. Yeah, do I believe? Yes, I do. Because why is it that lupus is in the childbearing age, even in adults? And specifically when children hit puberty, then disease hits in. So that's the experience from the clinic. But if when the GWASs were done, everyone was just looking at all the hormones, and then if there were SNPs in this field, and as far as my knowledge goes, it never was a really good explanation why it's primarily females and why it's primarily the childbearing age. So yes, clinically there is. What's the explanation? I'm not sure yet.
Okay, thank you. There is the last question with thanks for the great talk from Lupus Madrid. And can you talk, probably we have not sufficient time, but a summary or key points talking about the management of neuropsychiatric lupus in pediatrician patients. So I know that it is a topic to be
it's for new lecture.
In another lecture.
Yeah.
But just some key points in order to...
Yeah. Okay, so I actually have a study on neuropsychiatric lupus right now, because I think one of the key points in neuropsychiatric lupus is that we don't recognize this correctly. And just a little background then, if you compare, for example, if you do MRIs of the brain in lupus children with lupus in general, if you compare to healthy controls, it's different. So they have more CNS abnormalities than healthy controls. But if you compare the ones that have defined CNS lupus by their treating physicians and those that have not, there's no difference. So we have no clue, actually. We have no clue. We actually can say from this data that we're not doing a good job yet to recognize it. And so first of all, the management is be suspicious. A lot of children with lupus have headaches. If you look in the SLEDA, you need to have a like morphine dependent or like headache to be scored as a lupus headache. So I have never scored in my cohorts a lupus headache, but it's amazing how and worrying a little bit how in those patients that have headaches a lot, I always are more keen to look for neuropsychiatric lupus. So those patients you will have to ask more in detail regarding cognitive impairment. Specifically ask for school, how they perform in school. And if you look closely, if you ask closely and more detail, just ask for if their grades went down, if they couldn't memorize that well. That's the great thing in pediatrics, that there's school that does tests all the time. And even you can do, and most schools, I think international, will do regular testing just for, deciding which level they are. And if they went down in the year before they got the diagnosis of lupus, it's really suggestive of neuropsychiatric lupus. So that's one thing regarding the recognition. Regarding the treatment, when I started working with lupus, and I think that's what a lot of people did 10, 15 years ago, we already also gave all our patients with with CNS abnormalities or CNS lupus, we gave them cyclophosphamide because that was the treatment of choice. Now, while having developed more experience, while having seen recognizing, I think CNS lupus more in a less severe sense, we also say sometimes they might have CNS lupus even if we're not sure, but if they have other reasons to start MMF, so MMF is our medication of choice in all patients with lupus, so even also in the joint problems. But I would start MMF, and actually a lot of patients do well, specifically the cognitive decline or the cognitive impairment, I would say, do well on even just starting MMF. And I have had a big discussion with the neurologist here in my hospital who are very into neuroinflammatory diseases, but they also value the MRI and also that neurocognitive testing a lot. But sometimes the neurocognitive test, often the neurocognitive testing is not showing a really strong, like solid proof that there's something going on. They're teenagers. It's kind of hard, but it's just, the function in school and also the memory, I would say, really helps you in saying if the patients improve. The reason to do cyclophosphamide, I think, would be with a blunt CNS vasculitis. Like a profound blunt CNS vasculitis, I would choose cyclophosphamide. But again, we have a very specialized department of neurology here on neuroinflammatory diseases, and we also have lots of experience now with rituximab. So I would always consider cyclophosphamide, but I think our first approach is MMF and rituximab in those patients, and maybe even add in cyclophosphamide if this doesn't work within a few weeks.
Okay, thank you. Just if there are no questions, I can see just a last question from my side, just a curiosity. Do you think that childhood onset lupus patients have major problem or less problem with adherence to treatment compared to the other or not?
Oh, yes, for sure. But this is just a disclaimer. If you don't check your levels, even in the adults, you don't know if they take it. So that's another thing why I like MMF a lot, because you can do levels. And I'd started out with just that I was doubting if they would take the medication. So then I found, to my surprise, much more zero levels than expected. So all of our patients get at least twice a year, just a random level of MMF. And I have midday, like afternoon clinics. So they should take it in the morning. It's really nice. So you don't have the top level. So if I have a top level, I know that's what we always ask them. When did you take it? And then a lot of those teenagers sleep in. If they go to the doctor, they don't have to go to school. So my clinic is only at 2, so they only rise up at 10. So I can have top levels. But I must say, it's quite surprising how often you have very low or zero levels. So yes, it's a big problem. I think all teenagers stop taking them at any point during their disease. If I follow them to 18, I think everyone does it. It's also sometimes a sign that they feel quite healthy, and I still learn by how to tackle this. And actually, I don't trust my judgment for taking it. I have patients that said, oh, when I said, you're taking in the morning 2 tablets, in the afternoon. Oh, no, we discussed I should take 2 in the morning and 1 in the afternoon, because da-da-da. And I did a level 0. And then I just phoned them and said, oh, you're not, it's 0. And how is it possible? And then they're like, oh, yes. Oh, yeah, it's in my bag. Oh, maybe I don't take it that often, So yes, it's a big problem. I would advise to do, well, even in adults, do random levels. And I think Natalie Costadeau has quite nice data on that, on compliance. And yeah, of course, in teenagers, it's much more. And it can be difficult.
Thank you. Thank you for this. And finally, just a final take-home messages for the adults rheumatologist. If you can summarize in a couple of words, 2, 3 words, a message on what rheumatologists of the adult should be aware and pay attention to a childhood onset lupus patient. 3 words.
Yeah. Oh, I actually have. So, and I didn't prepare, but it's in my talk. I didn't know you were answering, because maybe people would say, oh, you prepared this together, but we didn't. But I would say age-appropriate care. I think that's the most important. Age-appropriate care, psychosocially, like they're having a chronic disease for some years already, but also regarding the complications of the disease. See them not as a new patient with lupus, see them as having 10 years of disease and being at risk for damage, for serious damage. I think that's the best advice that I can give.
Thank you. Thank you so much again for this very, very interesting talk. Thank you.
Okay, thank you. Thank you for asking me. I was happy to deliver this. I hope the audience has enjoyed it.
Yes, I think too. And thank you to the audience, of course.
For joining in.
Thank you and bye-bye.
Bye-bye.